Welcome back to the Nursing Post podcast, All Nursing All the Time with Ashley and Rosa. Today we discuss long haul COVID or long COVID. And as always, our goal is to inform and spark conversation.
So I am sure at this point that everyone is literally sick and tired of COVID-19. I know, like at this point, we're kind of numb to it. We're tired of hearing about it. But the reality of it is we're going to keep hearing about it. That's just what it is at this point. I guess this is what the new norm is. And if you have lost loved ones or have actually suffered with the virus itself, then you out of everybody is probably sick and tired of COVID. And when someone who's contracted COVID-19 generally would recover, let's say in like 6 weeks, they would tell us, the cough lasting the longest, generally with any cold, right? And COVID-19 is in that family of the common cold. But this is not a common cold because now we're learning that there are long haul COVID patients. People who persist and continue to have COVID symptoms beyond that 6-week period.
And it's not just a couple of people either that have symptoms. That's kind of one of the big things that I think as a healthcare industry, we really are going to have to focus on what are we going to do for a huge influx of patients who are still going to have these symptoms. What we know right now is it's estimated that 114 million people have contracted COVID-19, and this is according to the CDC. Of course, this is an estimate. It's not an exact number because not everybody goes and gets tested nor can get tests done because at certain points
there were issues.
Yeah, we just didn't have the actual test. A third of the patients who have contracted COVID still have COVID symptoms 3 to 6 months after an infection. And 10 to 30% of patients who have had COVID are still experiencing debilitating symptoms, which is crazy to me that this is affecting our bodies in the way that it is. If we think about that, if there's 114 million-ish people who have had COVID and 10 to 30% of them are still experiencing debilitating symptoms, that's millions of patients.
Absolutely.
Who are still having problems. It's not a couple thousand. This is millions.
And I think at some point you're going to be bound or tend to catch it.
Oh yeah.
Or some variant of it. We're on our 5th one now.
Yep.
So it's doing what viruses do. You adapt or you die.
Yep.
And it's adapting.
And we've known this, This is not anything new when it comes to viruses. Rose and I didn't discover something crazy, thought process. When we first launched our podcast in 2020, we didn't intend for our very first episodes to be on COVID.
That's just what was going on at the time.
It was so new, and there was so much misinformation or lack of information in any one spot that we had done a 3-part series on that. And we had said that it's a virus, it's going to mutate because that's what viruses do. Period.
And we see it every year. I mean, even if COVID didn't come along, we see it every year with the flu.
Yep.
So, and this isn't going to be the last, COVID.
No.
In the family. Like I said, we're on the 5th variant. You never know what the future holds. And we're not going to know the long-term effects because it just hasn't been long enough for us to collect the research and do the studies. So it's always going to be evolving. You know
exactly.
what I mean?
Some things take time, and there's no way to rush it. The time just has to pass. There's just no way to speed that process up.
I agree. A lot of you might be asking what long haul COVID is, and we did just discuss that. The CDC states that COVID-19 is a disease caused by a virus named SARS-CoV-2 that most often causes respiratory symptoms that can feel much like a cold or a flu or pneumonia. Mm-hmm. And that it attacks more than just your lungs and your respiratory system. Yep. So when you have long haul COVID, it's difficult to define because they're, for lack of better words, it's still current, it's still evolving, it's still changing. Mm-hmm. And it's not cookie cutter. It's not one symptom fits all patients. A patient might have one symptom, another patient might have 2, another patient might have like 5. There's no cookie cutter situation for a long hauler. There just isn't.
Nope.
There are a couple of signs and symptoms for those who are currently affected by long haul COVID. The main one is difficulty breathing or shortness of breath. I think that one in and of itself was probably one of the first leading signs for patients to haul their derrieres to the emergency room.
Yep. It's a whole other feeling when you can't breathe.
Absolutely. I have asthma, and when you have a flare, it's like breathing through a pinched straw underwater. Mm-hmm. So I can only imagine what this feels like, because I need to knock on wood. I haven't had COVID, or if I've had it, I didn't know I had it. But then, I am triple vaccinated. Maybe the vaccine did its job, and that's why I didn't know.
Right.
So we'll just keep moving along. But for people to have felt so bad in the beginning, for that to be like one of the leading causes for them to go to the emergency room and to still have that same symptom 3 to 6 months after, like every day feeling like you're breathing out of a pinched straw, that has got to be one of the most horrible feelings ever.
Yeah, that's one of those things that I definitely cannot relate to. I've never really had an issue breathing. The only time I get short of breath is if I run. And that's a lot different.
So silly.
That's a lot different scenario, but working in an outpatient clinic, you can tell patients, they're like, it's just not right. I'm not back where I was. And it's sad because I think that they're treated differently.
I think they are. I think that doctors and maybe some nurses are starting to get numb to it, numb to COVID, because it's oversaturated. It's saturating everything. Everything for the last 2+ years now has been nothing but this COVID variant, Delta, Omicron, blah, blah. And so people are getting, unfortunately, numb. My suggestion for those people who are in the medical field, if you're starting to feel numb about the care that you're providing, then maybe you shouldn't be providing care.
Yeah, they need to take a hiatus. The problem is who's going to replace those nurses who need that break?
That's the problem that we've had since before COVID.
Yeah.
Yes, it's now magnified, but I would rather have a nurse that is not numb and cares than one that just sees me as
another patient.
898 COVID-19. You know what I mean?
Oh, yeah.
Along with the difficulty breathing or the shortness of breath, a lot of people are feeling very tired or fatigued. And the symptoms get worse after physical or mental activities. I think the one thing that surprised me was when one of our former PAs had contracted COVID. And she was in recovery, and she kept saying she's got this difficulty thinking and concentrating, and that she still has the brain fog from COVID-19.
Yep.
That, to me, between the breathing and the brain fog, I would be
useless.
Excuse my grammar, no more good. I would be no more good for nobody.
Yeah.
My double negatives and my bad grammar. So, but honestly, I'd be like, what the fudge?
Yeah. Well, and again, people that are in the healthcare field are constantly exposed to COVID. So we know if you're constantly exposed and exposed and exposed and exposed, even if you're doing everything right, shit happens. And so
that's just the way it is. You know, when you take on that risk, it's a responsibility as well. And you know that that's a potential outcome of that. Mm-hmm. It's not any different than, caring for somebody with Ebola. You still have to gear up and do your PPE, but that is what you know comes from potentially taking care of a patient mm-hmm. that has this type of illness or any other disease,
Oh, yeah.
They also tend to have a cough. They can have chest or stomach pain. If you're coughing, all of that's going to hurt. So mm-hmm. that makes sense. You're going to have a headache. Yes, you're going to have a headache. You might have heart palpitations, muscle and joint pain. That viruses cause that. Pins and needles, that feeling of pins and needles in your extremities, diarrhea, sleeping problems. You can have a fever, lightheadedness, a rash, your mood changes. If I had 2 of these, my mood would change. So I can imagine if you have any more or just one, I know people's moods are going to change. I think the thing that I find most surprising is the fact that some people, like, friends and family will tell me who have had COVID that they still cannot smell and taste.
Mm-hmm. Or if it comes back, it's not the same.
It's not the same, mm-hmm. which is, it's crazy to me because, if you enjoy eating, mm-hmm. or if you're like me, you smell what you eat.
That's normal.
Bad, I'm not going. I'm just saying, if it smells bad, I'm not going to eat it. But if you can't even enjoy your food because, the smell is part of the taste. It kind of works together. And if you're missing one, I can see why somebody would lose weight. You know what I mean? And nothing's appetizing. Nothing's pleasing.
Absolutely.
Tastes like nothing.
Both of my kids go to an orthodontist, and the lady that comes in and kind of like does like the little adjustments and things. I don't think she's a hygienist, but I don't know what her title is. I've never asked. She had COVID, and she said that everything she eats tastes like raw sewage.
That is disgusting.
And she's lost like 15 pounds because she has to force herself to eat because she said everything just tastes like sewage. She described it as
awful.
Raw sewage, which I don't know if that's a term that I'm not familiar with, but yeah.
Wow. Yeah. I have not heard it defined as that. I've just heard it like a lack of, what I mean?
Some people, there's another lady I work with, I don't even know. I don't know how I escaped it. It went through my entire office. And I'm the only one that was like, meh, no issues.
No, to this day, from what I know of, knocking on wood, I don't think I've ever had it.
Yeah, and
I
so
hope never to.
Like our whole front office got wiped out, the whole nursing, like everybody, like it went through the entire office, and everybody was just looking at me. They're like, "You good?" I'm like, "Man, y'all stay on your side of the hall. You stay on your
You stay over there, and you leave me over here."
Right.
This is like a situation where sharing is not caring. And you need to keep your cooties to yourself. Yeah.
So I don't know. I don't know how I've escaped. And my husband worked for the school system for the longest time. He's not had it that we know of. My kids are in the public school system. Every day I'm like, they're going to bring it home. They're going to bring it home. They're going to bring it home. Because they're nasty. I love my kids. I love kids to death. The kids are nasty.
They are
little, so it's not so bad. But they touch things. They put things in their mouth. They put their hands in their mouth. They're always touching their face. The kids are gross. And I'm just like, oh my gosh. Because I know my luck, if I get it, I'm going to have something affect my taste or smell. And then I'm just going to be devastated because how much I like to eat. It's going to be awful. And I'd be that person where stuff tastes like sewage. And I'd be like, I don't know.
I would just have to put extra Texas Pete on that bad boy. I mean, I said extra because I already use it for everything, but just to have like a little bit, a kick or something, like I just have to pour some Texas Pete all over it and just hope that,
I'm like,
it works.
My sister had COVID. She's been working saturated in COVID. She works in a small town, and their office is pretty much, I think it is the only one within probably a 30, 45-mile radius that even tests for COVID, treats it, does anything with it. So she's, spends part of her day all garbed up, testing, seeing patients. And as she finally got it, which I think her kids brought it home from school, that's what we speculate.
There's a little germ monster.
I'm telling you. But she even said her taste and smell wasn't right. That she's like, it's just not, things just don't taste right. She didn't have a way to really explain it. And I'm just like, man, please. If I get it, I want to get pneumonia. Then you take away my sense of taste.
Oh my gosh.
Yeah, antibiotics can fix that shit.
I don't what's that saying? I don't live, to eat. I eat to live, but I like my food to taste and smell good while I'm eating to live,
Yeah. Yeah. I'm kind of somewhere in between.
So you could have one or all or a few of some of these symptoms, and there are more. And as research continues and the more studying of the symptoms are done on these long haulers, I think we'll know more in the future. Everything is still changing. I mean, at this very moment, it's changing. The last time we did an episode, there was only 4 variants. And now today there's 5 variants. Who's to say by the time that we post this that there won't be 6? So just be patient. Science is literally about numbers, not necessarily speculation. And because of that is why it takes so long for definitive answers sometimes. And I think people forget that.
Oh, I agree with that wholeheartedly. But me being the person that I am, would like to kind of talk about the elephant in the room a little bit. And that really goes to just disbelief altogether. I'm already seeing this where I work. Already seeing it. And there are times I'm like, man, we just don't know enough about this disease process to not believe patients right now. Do not get me wrong. Are there patients out there that are crazy and want something to be wrong when there's nothing wrong? Abso-fucking-lutely. There are. There's a name for that.
That's a whole nother episode.
Yeah. However, when we have a new disease process, a new virus, and we don't really know what's going on with it, we don't really know how to treat it. We think we do, but where it's ever evolving, I don't understand how anybody in healthcare can just say, oh, I'm not going to believe somebody and what they're saying that their symptoms are. Especially people who don't go to doctors, don't really complain, and you know who those patients are. It doesn't take you long in the healthcare field to figure out the ones that call every time they have 3 hiccups in a row, and the ones that don't call, and by the time they end up in the hospital, it's like, yeah, we needed to see you 3 years ago. So there's you can tell. Of course, not everybody fits those stereotypes, and I get that, but if you work in the medical field, you understand that statement. If you don't, then you're not going to understand it, and I don't care. But there was an article in the New England Journal of Medicine that talked about long COVID. And for anybody who doesn't know, the New England Journal of Medicine, you have to subscribe to read their articles. And it's a peer-based review journal. It's great. I love it. Right now, everything revolving COVID-19 is free. So you can read all their articles for free on their website. It's really great. It kind of validated my thought process a little bit, because it wasn't like, oh, here, it's not just Ashley thinking that people are being ignored. No, people are being ignored. It's not new in healthcare, we know that, but people are being ignored. And I've literally have heard providers say, well, everybody thinks it's because they had COVID. Well, if they didn't have a problem and then they have COVID and now they have a problem.
And how can you rule it out?
Yeah.
How can you say it's not from it when nobody knows at this point?
Exactly. And if you heard this once every several hundred patients, yeah, I would be more inclined to believe you. To say, well, yeah, maybe it's not. Not everything is COVID's fault. And I agree with that.
That's true. That's a true statement.
It doesn't mean that patient after patient after patient after patient after patient's wrong. When you start seeing a pattern, then the coincidence goes out the door. That's pretty, and I mean, come on, that's like, to me, that's common sense. I think that part of the reason why there's kind of a disbelief of long COVID is because there's not really a way to test to see if you have long COVID.
It kind of reminds me of the pain scale.
It's subjective.
Exactly.
And I understand that. And they can run tests and, CTs, chest x-rays, PFTs, labs, everything come back normal. Okay. Doesn't mean I don't feel like shit. Doesn't mean I'm not still having problems. And I'm like, So, of course, this article will be linked, and it's not very long, and I would recommend anybody that has a moment to read it. I think it's a really good article. But there is an overwhelming number of people that are in the medical community that are disregarding patients' symptoms when we know that well over 80% of patients who leave the hospital are still experiencing symptoms beyond their baseline. And when I say 80, I am being very conservative because I've read multiple articles and those numbers are actually quite higher than that. I'm kind of rounding down a little bit. I'm sure there's some articles that I missed because there's no way I can read every single one.
I don't even think it's just that, Ashley. This is a whole nother episode, but I read somewhere last night in the news in which they feel like the CDC has not been completely honest and forthcoming with all the COVID data.
Well, I'm surprised. It's a government-run organization.
Exactly. I'm not surprised at all. So it's kind of hard to talk about numbers and what the true numbers are, because at this point, with that information being, I guess, leaked, there's no telling what the numbers are.
Well, and that's why I like to look at things like the New England Journal of Medicine. I also like to look at another journal. It's called the BMJ. I just find that their studies are a little bit more different. It's based off of information received from the hospitals. And so we know if you were hospitalized because of COVID, then you probably had worse symptoms. That kind of goes hand in hand. Of course, the people that died at home aren't necessarily included in this because they died at home. But then on the other hand, I'm like, if more than 80% of your patients who are leaving the hospital at least have one symptom, at least, and the majority had 3 or more, especially if they were intubated and come home, they had 3 or more. Then why are we discounting them? Like, oh, you left the hospital. Yeah, we know you had COVID. Yeah, we know that your symptoms hadn't resolved, but you were well enough to not be in the hospital, which is great. That's all normal. But you go to see your primary care or you go to see a specialist because of whatever's going on with you post-COVID, and then all of a sudden nobody wants to believe you. Like, where's the disconnect?
It's all over the place.
And I'm just like,
From A all the way to B and C.
Another thing that was mentioned was that women are affected more by long COVID than men. Well, then I'm like, that says a lot. That answered a lot of questions for me immediately when I heard that. And I don't try to blame everything on being a man or a woman. I don't look, whatever. But again, we know that women are not listened to. It's all, oh, it's psychological. It's in your head. No, not every woman is crazy.
That drives me nuts.
And to add fuel to the fire, if you're a black woman, you're really up shit creek without a paddle. Because at least the white women will get some testing done as to where if you are a black American, it's like, well, yeah, we won't even give you what we gave the white lady. Like, I don't understand where that roadblock is.
I don't understand it either. We all take a pledge, whether you're a doctor or a nurse.
Mm-hmm.
Pretty much they both say do no harm and, to always be honest and have your patient's well-being and interests at heart. Like that's the whole, they both pretty much say that in a nutshell.
Mm-hmm.
So I don't see how you're able to do that when you are purposely putting barriers in place as a provider to block care.
It absolutely, and I know we were talking.
I don't care if you're pink. I don't care if you're orange. I don't care if you're polka dotted.
Mm-hmm.
Like everybody should be treated the same. Now, not every patient's cookie cutter. That's not what I'm saying. But whatever test you're offering from one group with the similar symptoms, you should be offering it to every group that has the similar symptoms.
Exactly.
Regardless.
It should be, it's called a standard of care for a reason. It should be standardized. Like if I go in complaining of heart palpitations and you offer me a heart monitor, well then Rosa, when you walk in and complain of heart palpitations, you should be offered a heart monitor as well.
It makes sense. So why it's not happening is beyond my comprehension.
Right. And it literally happened the other day in clinic where I physically mentioned, hey, are we going to put a heart monitor on this patient who is complaining of palpitations and shortness of breath after COVID? Oh, yeah. I'm like, oh, yeah, oh, yeah, oh, yeah. So had I not said anything, would it not have been done? Of course, you can't answer.
Not.
I can't answer that with certainty, but I bet some good money that patient was about to be let go with. It's going to take a little bit more time for you to feel better. Let me know in a couple of months if it's not better. And by that time, the patients are so defeated, they're just like, whatever. And they quit complaining about it. I
can only imagine at some point, they're the ones feeling like they're lunatics because that's how healthcare is making them feel.
I had a lady one time that literally was told that something was wrong with her and she needed to see a psychiatrist because she was short of breath. Did some testing. I just listened to the lady. And, nurses have a certain amount of autonomy. If this is what's going on, we need to do X, Y, Z. If this is what's going on, you do X, Y, Z. Like somebody comes in, they're complaining of fever and a sore throat, you do a strep swab. It's kind of like standing orders. So same difference. Well, ultimately, this lady has some issues, did some tests, come back. Guess what? She had a real problem that could really be fixed. And to this day, when she sees me out in public, she will stop me and thank me and hug me. And this lady is a professor at a university. So she's educated, which really should not matter. But they treated her like she was an idiot.
Well, that's to the point that you were making before. Women supposedly are more affected than men are.
Mm-hmm.
When you look at it as well, aren't men the ones who least often seek medical attention or just even routine medical care?
Mm-hmm.
Just saying.
And another thing that I was thinking about when it comes to this long COVID is, say I got sick, and I'm not one to go to the doctor very regularly. Rosa knows this about me. I feel like an ibuprofen can fix most problems.
With my mom, it was Vicks.
You know, like it is what it is. So I'm telling you, and I'm okay with that. Like everybody's like, oh, maybe my kids like, Mom, ibuprofen can't fix everything. I'm like, yeah, but it fixes a lot. And if that doesn't work, we got Tylenol. You know, like we have. But you know, if something's wrong, I'll go to the doctor. But you know, I'm young, I'm healthy, I don't have any pre-existing conditions. The only person I see regularly is my dentist and my OBGYN, and that's because, well, the dentist is pretty self-explanatory, and the OBGYN, I wouldn't even see them if I didn't need my birth control. Okay, I'll be honest with you. It's not what you should do at all, but you know, we all can't be perfect. And if I got sick with COVID or thought I had COVID, I would do a home test. That's what I would do. If I could get one. If not, I probably would ride it out unless I was like unable to respond and somebody took me to the hospital. I wouldn't go to the doctor. I'd be like, oh, it's positive. Okay. I probably would text my boss. This sucks. 2 lines. Because I'm not pregnant, so that's what I have. You know, kind of thing. Stay home my 5 days or whatever, and then take my little happy butt back to work. I wouldn't even involve a doctor because for the vast majority of people, that's okay.
Well, now they've made it to where it's over the counter, and I understand the point of them doing the COVID test over the counter.
Mm-hmm.
But just like everything else that's been put over the counter, like GERD medication, allergy medication, and other things,
Mm-hmm.
when you're self-treating,
Mm-hmm.
it's a guessing game.
Oh, absolutely. But my thought process is, if I do a COVID test, it comes back positive, I'm fine. But then I realize, you know, I'm waiting it out, not going to the doctor. It's going to get better. And it doesn't. I finally go to the doctor and I'll say, yeah, well, you know, I had COVID, you know, a couple months ago and I'm still not feeling well. Oh, where were you tested? Well, I tested myself at home. It was positive. Okay. I don't think a provider is going to have an issue with that. But what happens if they need to do testing and insurance is like, well, there's no history of her going to the doctor and having a positive test. Like, give me proof that she had COVID before I pay for all these post-COVID, you know, tests. And I can't supply that because I didn't go anywhere because I did a home test. Is that going to create a problem? Because in my opinion, insurance will do anything and everything that they can do to get out of paying for something.
Pay. Absolutely. Because they don't want to pay. It all, like I said, it always boils
down. So I wonder what bag,
cents,
you know, is going to be unleashed when that starts happening.
Well, it's going to have to be listed as what I think as a pre-existing condition.
Mm-hmm. And then,
even though there's no way to define it.
Right. And then that gets into a whole other issue. And so
a lot of red tape.
It does. And so I wonder not only for this long COVID and like patient symptoms, how it's going to affect just their life, their quality of life, and or their quantity of life, but what about other issues that are going to arise that we're not really talking about right now?
Well, I think that just goes to show that COVID-19 is ever changing. We know of 5 variants. It does have the potential to continue to mutate. That is, this whole experience is still new. 2 years is not a long time in the medical research field. Honestly, it's not. You know, there's medication that takes longer than that to be made and to be discovered. And so,
absolutely.
So, you know, 2 years is nothing in regards of what we still need to know and learn and study and research. And as nurses and medical professionals, we have to address the post-infection condition. And like I had mentioned before, you know, it's like pain. It's whatever the patient says it is until it's not. And so we need to do our part and our due diligence as medical professionals to address the conditions.
Mm-hmm.
And while we're doing so, to continue the research and the data collection so that we know in the future more and are able to help better.
Mm-hmm.
So
I agree.
It will take years. 2 is not enough. I don't even think 4 is enough.
No.
I'm not sure if 10 is going to be enough. You know, some of these people are probably going to have to be followed and research and study for the rest of their life.
Mm-hmm.
But hopefully, in a couple of more years, we'll have more information then than we do now.
Oh, I think that it's a constant collection of data. And the more data we have, the more we know. And some people are like, well, that doesn't really tell you anything. It really does. In the medical field, that's how we do everything, is off of numbers. And we would then know, hey, there's, you know, an 80% likelihood of you recovering if you do X, Y, Z. And we like this. We like those numbers. We like those odds. We like explaining that to people. That's why you and I think so much like statistics and things. It's because that's like what's ingrained in us with science, is having stuff to back it up. And I just find it so disheartening that we know that we are having patients leave with symptoms not at baseline, and then once they get into the real world, it's like, sorry, you're still having problems. So hopefully, I guess if there's a provider, and I don't care if it's an NP, PA, doctor, DO, whatever, somebody who can write a prescription and order tests, I hope that we can put certain issues aside within the healthcare industry and say, okay, hey, look, this person has this complaint, we're going to work it up, period. They're like ordering tests for everything else. So, I mean, just go ahead and do it. And it doesn't matter what gender they are, what race they are.
Their socioeconomical status, religion, all that goes out the window.
Right.
The moment they step in and be your patient.
Right. And I think that for nurses like myself, knowing this literature and reading it is really important, because I read something the other day about post-COVID patients and the likelihood of POTS. And I'm like, okay, so when patients are coming in and they have complaints of lightheadedness, dizziness, palpitations, things like that, or they're passing out, having syncopal episodes for whatever reason, I've been doing orthostatics on those patients to see if they're having, changes, if they're having tachycardia. And I've done that because I know that I've read the research, and as a nurse, I can take orthostatic blood pressures. That's not an issue. Mm-hmm. So the more you know, the more you can help. And then that way, but when you're giving that information to your doctor, then they're like, oh, hold on. Her heart rate went from 80 to 130, standing up. No wonder she feels like crap.
That's our obligation as nurses, is to continue to expand our knowledge base so that not only we know more, but our patients benefit from that.
You can visit us on our website, thenursingpostpodcast.com, for show notes, references, and actually for our merchandise as well. You can subscribe to our podcast on your favorite platform, and of course, give us your feedback on the episode or anything you'd like for us to read. We love articles. And thanks again for listening to The Nursing Post.